Thank you for joining us for our 16th annual ALS Care Research Symposium. This year we're obviously doing it virtual, which is obviously a difference. Typically, I really enjoy seeing you guys in person. One of the things that does make doing a lecture a little bit different on this virtual format is I have no audience to feed off of. I also, with these talks, want to have questions, and it's obviously difficult to have questions via this manner. But in person obviously makes it more interactive, we'll do what we need to do. Oops, let me go back. I'm Dr. Fee. For those of you who don't know, I'm the co-director of the ALS Clinic at Froedtert Hospital and the director at the VA in Milwaukee. It's a standard thing for medical talks to make sure that you don't have any disclosures. I don't have any financial relationships with the drugs or the pharmacy companies mentioned beyond during the clinical trials. I did do a Biogen advisory board as a one-time event. The money that I received for that I did use for team building activities for the ALS clinic. But I was interested in a drug that they have for SOD1 mutation, and I wanted to learn more about that. And so that's the reason why I did that advisory board. As many of you know, you have participated in our ALS multidisciplinary clinics. I take every opportunity I can to go over the multidisciplinary clinic. It has been shown in a research study to provide the best survival benefit in ALS, and it also provides a huge quality of life benefit. And the vast majority of that benefit is from the therapists that are listed there. If you think about it, ALS is progressive weakness involving arms, progressive weakness involving legs, progressive weakness involving breathing, and progressive weakness involving speaking and swallowing. And what we have both at the VA ALS clinic and at the Froedtert Hospital ALS clinic is we have therapists that assess all those different areas. So we have physical therapy and occupational therapy for arm and leg issues. We have respiratory therapy to help assess breathing issues. We have dietitians and speech therapists to help with speaking and swallowing issues. And what they do is a couple of very important things. One, we try to get ahead of problems as much as possible. We're not going to stop the ALS from progressing, but hopefully we can minimize as much as possible the problems from that. The other huge benefit that they have is doing workaround solutions to maintain quality of life as much as possible. Additionally, within the ALS clinic, we have a number of wonderful nurses. I would be adrift if I didn't have Stacy and Doris. We also have support services, both for patients and caregivers. There's a variety of different ways this can be provided. The ALS Association at Froedtert Hospital, we have a chaplain. There's child life, social work, psychology involved. Another important aspect, and I'll go over this a little bit later on, is we have a wonderful research team, and we also have clinical trials to help assess and figure out if there are additional treatments that can help with treating ALS and minimizing the problems of this disease. Overall, we have around 220 active patients at Froedtert Hospital and around 40 or so active patients at the VA. The numbers are always difficult to precisely determine. And one of the big aspects of that is as the disease progresses, it does become a big hassle to come into clinic. And one of the things that ALS providers essentially across the world, not even just in the country, but across the world, is we've wanted to try to figure out how we could better incorporate video visits into ALS care. One of the fallouts of the pandemic is going to be that these video visits are here to stay. And so one of our hopes is that patients who have more advanced disease will continue to be seen, but through a video manner. Obviously, there is so much benefit that the therapists do on site that is very limited with just a video visit. But the hope is that as patients get more advanced, we can still be an active part of their care through video visits. But that's still a work in progress. We also do ALS Education. This is one of them. We host a symposium each year. Also, the therapists in the various clinics do a lot of support group discussions, both the physical and occupational therapy and dietary. Dr. Barkhouse is part of the lecture service circuit at the Medical College of Wisconsin, and he does talk about ALS to different groups at the medical college, the physical medicine and rehabilitation doctors. The other is the palliative care program. Dr. Barkhouse also lectures on a national level as well. In terms of our clinical trials, we have a few of them that are currently active and a few that are in the works. That's typically how we try to do it. No clinic is able to do every single clinical trial that there is. Most places have the capacity to do 2 to 4 at a time. Some places have less ability, so they're more 1 to 2. Some places have more. We try to have around 2 to 4 active trials at a time, with another couple in the works as those active trials close their enrollment and then go into the monitoring phase. The first study I'm going to talk about is actually one that by the time you view this lecture should be closed for open enrollment. It's a trial that's assessing oral edaravone. Edaravone's other name is Radicava. That was the medicine that was approved by the FDA around 2 years ago. It's the medicine that's delivered by IV infusion. The dosing of it is for the first 2 weeks, you get a daily IV infusion, then you take 2 weeks off. Then for the next 2 weeks, you get 10 out of 14 days of an IV infusion, then you take 2 weeks off. And until a person decides they want to stop the medicine, it's 2 weeks of getting the medication, 10 out of 14 days, then 2 weeks off. Obviously, there's a lot of hassle involved with getting IV infusions at that rate. We know that that degree of time spent getting infusions can be a huge burden in terms of quality of life. And so they are assessing to see if a similar effect, a beneficial effect, can be seen with giving that drug orally. And so this is a trial that is evaluating that. And as I said, by the time you hear this, it's probably going to be closed to enrollment. But I have a slide later on that says that we actually have 2 additional oral edaravone studies that should be approved, hopefully by the time you watch this. Another trial that we have is actually with edaravone, the Radicava, in its standard approved IV delivery. And what this study is trying to do is actually assess for what is called biomarkers to help us determine if there is a chemical that we can look at in the blood or a chemical that we can look at in the urine or cerebrospinal fluid that is a marker of either the ALS progressing or getting worse, or is there a marker that there's a change that reflects that the Radicava is improving the patient's condition. There's a huge area of research on biomarkers. And basically, they're another way of assessing for effectiveness of treatment. For what we are doing now, we're basically measuring or assessing one degree of strength or another. Our most objective way of assessing strength is by doing pulmonary function testing. We also ask basically the ALS functional rating scale that we have is basically a way of assessing how strong you are. And so we want to have other ways of assessing for effectiveness. And so that's what this trial is designed to do. We should have the Healy platform trial approved by the time you hear this. Our approval got delayed because of COVID, and we thought that we were going to be approved in April, and things got put on hold because of COVID. The Healy trial is actually designed to be a series of clinical trials that are not perpetual in the sense that they will go on for forever, but for the near future will be perpetual. What they are trying to do is have basically 4 arms of the clinical trial. One arm is the control arm, and then there are 3 different treatments for each additional arm. And the benefit of this is that one control group can be used for 3 trials, essentially. And so it minimizes the number of people who are on a control medicine. One of the benefits of that oral edaravone study that I mentioned previously is that patients knew they got the drug. So with standard trials, what we call placebo-controlled, double-blinded, the placebo-controlled is no one knows whether you're getting the experimental drug or you're getting the control. And we compare, obviously, control versus the experimental. A lot of people don't want to be in the control group. That's understandable. And so this trial is minimizing the number of people that are in the control group. If you remember, I said placebo-controlled, double-blinded. The double-blinded part is the patient doesn't know if they're on the experimental drug. I don't know if they're on the experimental drug. These are a way of trying to minimize bias in how we assess clinical effectiveness. And bias is a huge issue with clinical trials, so we do have to have a placebo arm to be able to do them effectively. And I mentioned this, we have a couple of additional oral edaravone studies that we hope to be approved by the time you're watching this. We have another 1 or 2 studies that are also in the early enrollment, not enrollment, sorry, but in the early phases of what's called site selection to see if we want to do the study and if they want to do the study. We don't talk about that, those studies, since it's so early. I felt that it would be okay to mention that we should be having these trials for the oral edaravone, because by all what everything looks like, we should be able to get them. We do have a couple of clinical research projects that Medical College of Wisconsin medical students are doing, and I actually take great pride in this. One of the biggest problems with many ALS clinics across the country is they're not able to find someone to replace the ALS doctor once they retire or once they need to leave. It is something that Dr. Barkhouse did exceedingly well with having me join him and having Dr. Sharilla join us just this past year. But my hope is that I am able to get more and more medical students interested in ALS, and so they're able to go out and serve the ALS community. One of my students, Samara, is doing a chart review project. There was a paper that was published around 3 years ago that assessed clinical markers for disease progression. and I'm having her assess our patient population here at the Medical College of Wisconsin to see if our experience here reflects what was published in that paper. The other student, Gloria, is looking at genetic characteristics of our ALS patients. There was a DNA collection, a genetic study that was done around 4 to 6 years ago. It was wrapping up when I started about 5 years ago. And this is a project using that DNA. And it's basically assessing if there are any mutations that directly cause ALS or may predispose for the development of ALS in our patient population. And hopefully she'll be able to finish that within the next year or so. Both Gloria and Samara entered their 3rd years, which is the clinical years, and they're beginning to learn that their time isn't as much as what they thought it used to be. But they're both working on these projects. I believe that Melinda Cavanaugh will be talking with you or having information about her work available. She does the youth care project, typically during the symposium in the basement. There's the kids are being not instructed, but they're being shown how to do things by the physical therapists, occupational therapists, dietitians, speech therapists involved with caregiving. Part of it is to make them less afraid of the equipment. Some of you know this, some of you don't know this, but my mom died when I was 7. And one of the things I did at 6 years old is pulled off her oxygen. And I thought I killed my mom. So this sort of thing where you destigmatize the equipment the care needs is actually something that's very important, but it's never been studied. Obviously, if you think about it from the outset, you know, there's some people that would view this as, oh my gosh, we're doing child labor sorts of stuff, and that's not what we're trying to do. The reality is that kids are going to be around their at-need parent, grandparent, and rather than having them fearful of what's going on, have them be comfortable. There's been 2 papers that have been published by this work. That information is put there. One of them was in the main neurology journal. It's just called Neurology, and that was published in April of this year. The other one was in a subspecialty journal that looks at neurodegenerative conditions, and ALS is one type of neurodegenerative conditions. The term neurodegeneration just means a disease that kills nerve cells. Dementias are a neurodegenerative condition. Parkinson's disease is another example. And that ends my lecture. Normally, I'd be very happy to take lectures, and we would probably be talking for another 20, 30 minutes before Angie would say we need to stop and go to another lecturer. But I hope you enjoyed this. Obviously, we want to do this in person, but depending on how this is how successful this is, we may be able to do further talks about this. If there's certain topics you would like us to discuss, just let us know. We can hopefully figure out a way of doing this. So thank you.